Good day to all. Thank you again for the invitation. I feel very honoured to be invited again to present to the general practitioners. My brief today is to really discuss the whole new concept of palm koyen, the new classification for the causes of abnormal uterine bleeding in the non-pregnant woman of the reproductive age group, really extending to the abnormal problems from bleeding point of view that occur between about the ages of 16 and 50 years of age. In order to appreciate the concept of the palm koyen classification, which is really the abnormal scenario, one's really got to know what is regarded as the normal parameters of menstruation. And the four classical entities that are important is regularity, cycle length, duration of the bleed, the menstrual period, and the volume. By definition, the onset of menstruation invariably is somewhere between the ages of 10 and 14 years of age, but one wouldn't investigate until the young girl is 16 years of age, provided she has secondary sexual characteristics. Important to bear in mind that we would now investigate a little girl of 14 who hasn't got secondary sexual characteristics. As a kind of medium throw, the range of cycle length is between 21 and 34 days. The duration is somewhere between 2 and 7 days, and the flow is between 20 and 80 mils on average, though somewhere between 30 and 35 mils. For normal menstruation to occur, it depends on normal FSH and LH or appropriate secretion of the gonadotrophins by brain, appropriate follicular development, subsequent to normal ovarian response, estrogen, progestogen, and with the development of oocyte comes the production of prostacyclin, thromboxane, and cytokine secretion, ultimately leading to the ovulation. With the release of the oocyte comes the development of the corpus luteum, production of progestogen, endometrial response, and ultimately the shredding, which is responsible for the menstruation. Again, the impact of the above-mentioned cytokines then acting on vascular arterial supply of the endometrium, leading to vasoconstriction and clot formation in the endometrium, and subsequently stopping the menstruation. And along with the issues that have arisen in the reproductive age group with abnormal vaginal bleeding has come the acronym developed by FIGO, a process taking 5 years, of combined contribution from 17 countries. And the primary function and development of the acronym has been to improve assessment and management of the abnormal uterine bleeding in clinical practice. And it really revolves around the causes, but at the same time structuring a uniform approach to abnormal bleeding in these patients. By definition, abnormal uterine bleeding being generally bleeding from the uterus that is abnormal in regularity, frequency, volume, or duration in the non-pregnant woman. Now, the old terminology, one still alluded to menorrhagia, polymenorrhea or polymenorrhagia, metrorrhagia or menometrorrhagia, menorrhagia being heavy, regular cyclical bleeding, as opposed to metrorrhagia or menometrorrhagia, heavy abnormal bleeding or intermenstrual bleeding. And as an ethos, the kind of umbrella was that it was either an organic cause, which we'll discuss, or if there was no organic lesion, the so-called dysfunctional uterine bleeding, which was abnormal bleeding in the absence of organic pathology, infection, fibroids, malignancy, and pregnancy being the primary concerns. This terminology, dysfunctional uterine bleeding, has been chucked out, and we'll allude to the newer concepts. And then as a small gamut of patients in abnormal bleeding, where we had to consider endocrinopathies, blood disorders, and iron deficiency. From the endocrinopathy point of view, the most important being von Willebrand's disease, and the blood disorders is really primarily primary thrombocytopenic purpura, afibrogenemias, and then the iron deficiency. Now, this is what's now the current terminology, and to be replaced with the new terminology. In the old dysfunctional uterine bleeding terminology today is divided up into purely coagulopathy, endometrial dysfunction, and ovarian disorders. Menorrhagia in broad sense is now termed heavy menstrual bleeding, and metrorrhagia intermenstrual bleeding. Now, from the abnormal uterine bleeding perspective, it's now divided up into acute, which is really an episode of heavy uterine bleeding that requires immediate intervention, and it can either be spontaneous, but it's not the typical chronic abnormal uterine bleeding, which by definition now is bleeding for more than about 6 months, but generally at least 3 months, unpredictable and excessive in amount. The PALM coin acronym, really the PALM component, really looks at the structural entities that can be measured visually by imaging, sonography, histopathology, and the COI-IN component being unrelated to structural or organic abnormalities, and refer to the coagulopathy, the ovulatory dysfunction, the endometrial component, the iatrogenically caused abnormal bleeding, and the not yet classified. The PALM component with organic problems really pertains to uterine polyps, adenomyosis of the uterus, leiomyomas of the uterus, and or malignancy. Each one of the letters alluding to one or two of the specific components. Now, when one looks at the individual etiological factors by kind of short, brief overview, a polyp really refers to an epithelial proliferation, which invariably has a vascular, a fibromuscular, and a connective tissue component. Of note, they can be either endocervical or endometrial, and they can be benign or malignant. Of note, it's important the treatment strategies depends on the location, the number of polyps there are, and obviously the morphologic and histologic features. Invariably, this will be seen. Patient presents with severe abnormal bleeding, an ultrasound is performed, or just simply on speculum examination, an endocervical polyp can be seen, but the ultrasound will invariably confirm or lead to suspicion, and the diagnostic procedure being hysteroscopic DDNC as the parameter to make the diagnosis. The definitive management at the moment is still hysteroscopic confirmation and or biopsy and or a DDNC, which will not only be therapeutic, but at the same time will be diagnostic. Adenomyosis. Adenomyosis is the presence of glandular endometrial tissue within the myometrium of the uterus, being confined to the myometrium as opposed to endometriosis, which is the similar notion of glandular endometrial tissue, but not within the paradigm of the confines of the uterus. The diagnosis of adenomyosis depends on visualization, invariably by ultrasound, although very rarely, sometimes we do need a MRI to make the diagnosis. Of note, it's invariably a gravid patient, generally towards the latter years of the reproductive age group, and on vaginal examinations has an irregular uterus in outline and very tender areas to the uterus itself. What are the transvaginal ultrasound criteria for adenomyosis for the general practitioners who are doing some gynae? It's this globular uterine configuration with a thickened myometrium, multiple echogenic linear striations with irregular myometrial cystic spaces, and this heterogeneous myometrial echotexture to it. Leiomyomas, which is now the preferred term to fibroids, being another cause of abnormal bleeding, under the kind of ethos of leiomyoma, is a fibromuscular tumor, invariably benign, although about 0.2, 0.3% can present as leiomyosarcomas. Invariably, on history and examination, the diagnosis can be made, but we always follow up with at least an ultrasound to confirm it. Now, leiomyoma in the strategy of palm coin is the only specific cause that is subdivided into a secondary classification, and it can either be submucosal or other types being intramural, but with contact still with the endometrium, just intramural, or it can be subserosal, depending on, again, how much is kept in the myometrial wall and how much is out. Of the classification, in palm coin, size of uterus, single or multiple in numbers, the size of the leiomyoma, and the location isn't taken into account. However, in the treatment strategy, all those parameters are important. And any uterus that is roughly greater than 14 to 16 weeks in size needs intervention. Obviously, the multiples are more difficult to manage than single. The size of a fibroid can be very important, and the location, for argument's sake, is it cervical or myometrial, in a strategy of management from a clinical perspective, does make a difference. And this is just to really show you the whole classification, looking at from submucosal as the leiomyoma progresses or its location changes, not invariably the smaller fibroids are submucosal, larger fibroids are intramural, and the very large fibroids then start growing from intramural to subserosal, subserosal completely almost, and even having a pedunculated fibroid attached to the serosa. And then the last component of organic, as the palm component, being malignancy. Now, it's uncommon in the late reproductive perimenopausal woman, but with what we've noticed with the PCOS syndrome, obesity, the metabolic syndrome, and the unopposed use of estrogen therapy, about 20% of women who present with abnormal bleeding and malignancy are in the peri or premenopausal age group. It requires the minimum of imaging and biopsy, which we will briefly address. The transvaginal scans, I don't perform hydroinflation, but I always would do uterine sampling, and the uterine sampling of preference from a personal point of view being the Z sampler, and there are others, Papal, the Pipette, but the Z sampler is very good, and ultimately the gold standard being hysteroscopy, DD&C. From an imaging perspective, it's very difficult to use endometrial thickness as we do in the postmenopausal woman, but it does lead, the larger the endometrium, the greater the concern. And then from the Cohen components, the non-organic pathology or not structurally related to the uterus, the big one being the coagulopathy. Knowing that about 13% of the reproductive age women present with von Willebrand's disease or a coagulopathy, of which von Willebrand's disease is the most important. Remember, primary thrombocytopenia and afibrinogenemias is important. Now, von Willebrand's disease must become as part of the differential if a woman presents with heavy menstrual bleeding and one of the following: postpartum hemorrhage, bleeding after surgery or dental work, or two of the following, where she presents with bruising at least once or twice a month, nosebleeds at least once or twice a month, frequent gum bleeding, particularly after brushing her teeth, or a family history of bleeding. The ovulatory component may be due to endocrinopathies. We see it quite commonly, and it's almost invariably associated with polycystic ovarian syndrome, hyper or hypothyroidism. But always remember, mental stress can play a role, the overweight patient, the anorexic patient, or she presents with weight loss. The abnormality of ovulatory bleeds is usually at the extremes of this age. That young girl that starts off with menarche, and the young lady that's now moved into the perimenopause, up to about 50 years of age, common abnormal bleeding, commonly associated with ovulatory issues. In the perimenopause, it's anovulation, luteal phase defects, or persistent corpus luteum leading to the prolonged cycles. And again, remember that in your history taking, it's important to know regularity, frequency, duration, and volume. The greater the period is, the periods are regular, they frequent, with its constant duration, which each girl has as an inherent development, and the volume, more likely is that lady ovulatory versus anovulatory or abnormal ovulatory aspects. From an endometrial perspective, it's really by method of exclusion, where one's excluded all other abnormalities in the presence of normal ovulatory function. The menstrual cycle is usually regular and predictable, in contrast to the ovulatory abnormal uterine bleeding, and it's basically an abnormality in endothelin 1 in the endometrium, and then the production of these prostacyclins, thromboxane, and cytokinases that I was speaking about as well, with excessive amounts of plasminogen activator and vasodilators, such as prostaglandins E2 and E1. There is a group of people that believe chlamydia trachomatis and endometrial infection can cause endometrial issues, specifically if it's postpartum, post-abortal, or related to pelvic inflammatory disease and lead to abnormal bleeding. Iatrogenic, doctor-induced, and we commonly see this with the introduction of the oral combined pill, single gonadal administration, when we only use estrogens for whatever reason, or progestogens for whatever reasons, intrauterine devices. Remember that the onset after intrauterine device insertion is not uncommonly associated with abnormal bleeding. And drugs that commonly cause abnormal bleeding include the anticoagulants, the antidepressants, aspirin, hormone replacement therapy, the breast cancer survivor and tamoxifen, phenothiazines, thyroxine, and corticosteroids. And just simply going with how much is being used as alternative medicine, we've seen significant abnormal bleeding associated with ginseng, ginkgo, soy, and arnica oil. And then lastly, the not yet classified, and these include the rare and ill-defined conditions. We've had women with arterial venous malformations and people with myometrial hypertrophy. Now, if one looks at the whole perspective of the treatment strategies in the acute bleeding patient, or the patient who presents with that severe bleed, ensure hemodynamic stability, review aspects of ovulatory function. History is very important. Your examination is important, and don't forget the potential role of the related medical conditions and medications, lifestyle factors, particularly in the younger patient. And you must take in the management strategy the concept of whether that young lady wants continued fertility, and then the role of imaging. Initial laboratory investigations, do at least an FBC platelets, get an RH and pregnancy test in all of them, exclude bleeding diatheses by at least doing a PI and PDT, the activated PDT fibrinogen, von Willebrand factor, if she meets the criteria I spoke about earlier. And then lastly, the whole concept of factor 8 in the girl who we can't find a problem but continuously presents with abnormal bleeding. Don't forget other aspects such as thyroid functions, liver functions, iron studies, and then ultimately, is there any chlamydia infection? How do we investigate the endometrium? Endometrial sampling, if you're concerned. I don't certainly look towards endometrial sampling in the younger patient, but any patient over 40 years of age presenting with abnormal bleeding, I would do an endometrial sampling. But in the younger patient with persistent abnormal bleeding, despite treatment, it would be appropriate to do an endometrial sampling. Don't forget about transvaginal uterine scanning. Then the whole aspect is, do you have, when you evaluate endometrial cavity, the submucosal myomas, polyps? It's not 100%. The small lesions can be undetectable. And if it's suboptimal or you have a degree of suspicion, rather subject the patient to a hysteroscope, refer it where they can do it. Ultrasound and MRI will give you myometrial assessment. Now, if from the investigation's point of view, I said to you, if that patient is having a period between 21 and 34 days with an absolute frequency of once a month, the volume being relatively within the normal perspective, she's having ovulatory cycles. And ovarian abnormal uterine bleeding is typically irregular in timing and flow, and often interspersed with episodes of amenorrhea. But if you want to know more and she's persisting in trying to make a diagnosis, do a day 21, 22 serum progestogen, and that will give you a ovulatory perspective, or ultimately subject the patient to an endometrial sampling to see that you've got secretory endometrium as opposed to only proliferative. From treatment options, well, we can start off with either hormonal or non-hormonal Mirena, hormonal being Provera, 10 milligrams TDS for a week, and see what happens. Warn her, it will stop the bleeding, but she will have a period roughly about a week after stopping. Non-hormonal, which is my preferred treatment of choice, being cyclopapron or tranexamic acid. Start off, and provided the patient weighs over 50 kilograms, I give 3 tablets 3 times a day for 28 tablets. It's about a 3.5 day cycle, a course, but I use higher doses. If the patient weighs under 50 kilos, I'll give her 2 tablets TDS times 28 tablets, not days, tablets. If you find that that is inappropriate or there's contraindications to it, the Mirena, remember that the Mirena insertion will give you about 70–75% of patients amenorrhea. Warn them that about 20–25% of patients will continue having periods, and then subject the patient to surgical intervention, of which hysteroscopic resection and DDNC by far is the preference of choice. Endometrial ablation is being done, but certainly wouldn't be an option in the woman who hasn't completed a family or the younger patient. The question of myomectomy comes into it very commonly. The bigger, the larger the number, the more symptomatic the patient is, the greater the need for surgical intervention, myomectomy being one option. The other option being high frequency, intense flowing with ultrasound, focused ultrasound ablation for the odd patient which has particularly a single solitary fibroid, and then the question of uterine artery embolization. So in conclusion, the palm coin acronym was brought about to unify the whole aspect of treating abnormal uterine bleeding. And it's been implemented to improve evaluation in all the female age groups, provided they are in the reproductive age group. It's still new and will be further standardized in trying to bring across management strategies, interpretation, and research entities. FIGO claims they will spend every 3 years updating the palm coin, but at the present moment in time, what we have and what we've presented constitutes the palm coin classification. Please stick to the appropriate investigations, exclusion particularly of von Willebrand's disease, and then the whole concept of surgical intervention based primarily on therapeutic and diagnostics, and whether the patient has completed her family, as to look towards myomectomy and going on to hysterectomy. I thank you for your time and for your attention.